Welcome back to the channel that turns complex medical science into clear, useful insights. As always, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check everything with trusted sources. I'm Dr. Rezaian, and today we're diving into an important and evolving topic: the use of antibiotic prophylaxis for recurrent sinusitis in patients on biologic therapy. How does this work? When is it appropriate, and what are the risks? Let's get into it. Recurrent acute rhinosinusitis is defined as 4 or more episodes per year, each lasting less than 4 weeks, with full resolution in between. This isn't chronic sinusitis. We're talking about repeated acute infections. The causes are often multifactorial: anatomical variations, allergies, impaired mucociliary clearance, and sometimes an exaggerated immune response to everyday pathogens. Now, add biologic therapy to the mix, such as monoclonal antibodies used for severe asthma, chronic rhinosinusitis with nasal polyps, or autoimmune diseases, and you have a new layer of complexity. While these therapies can reduce inflammation and disease burden, they may also increase susceptibility to upper respiratory infections, including recurrent bacterial sinusitis. In these patients, antibiotic prophylaxis becomes a more relevant consideration. It isn't a first-line treatment, but when conventional therapies fail, including saline irrigation, intranasal corticosteroids, allergen control, and structural evaluation, it may be worth discussing. Good candidates for prophylaxis, especially those on biologic therapy, typically have documented recurrent bacterial sinusitis, no success with allergy treatment or immunotherapy, normal immune function otherwise based on testing, negative imaging ruling out chronic sinusitis. When prophylaxis is prescribed, it usually involves low-dose, extended-duration antibiotics. Common regimens include azithromycin 250 mg 3 times a week, amoxicillin 250 to 500 mg once daily, TMP-SMX single-strength daily. These courses typically last 1 to 3 months, particularly during high-risk seasons or periods of ongoing biologic use. Azithromycin is especially interesting. It doesn't just fight bacteria. It also modulates the immune response, which may offer additional benefit to patients on biologics, but that dual effect can come with trade-offs. Long-term antibiotic use carries real risks: antibiotic resistance at both individual and community levels, microbiome disruption affecting gut, nasal, and sinus flora, side effects like gastrointestinal issues, allergic reactions, and elevated liver enzymes. Because of these concerns, prophylaxis should be carefully considered and tailored, especially in patients already on immunomodulatory therapies. Documentation and follow-up are key. There are also alternative and adjunctive strategies: immunotherapy and allergen control, nasal saline irrigation, balloon sinuplasty or endoscopic sinus surgery, re-evaluation of the biologic regimen or timing. And on the horizon, we're watching developments in probiotics, biofilm disruptors, and bacteriophage therapy, tools that may offer targeted approaches without broad-spectrum disruption. So where do we stand? In patients with recurrent sinusitis who are on biologic therapy, antibiotic prophylaxis can be a valuable option, but it must be used with caution, clarity, and good clinical judgment. If you found this breakdown helpful, like the video, leave your questions or comments below, and subscribe for more practical, evidence-based medical insights.